Coordinator, and we couldn't forget Sherry, who weekly gets questions from us regarding the contract, the grant itself, and budget questions all over the place. I am a brand new PI on this project, so there are lots and lots of questions that get asked along the way. Here is a little bit of information about FORE. They are a national private grant making foundation, really started their work in 2018. And we were part of their first round of funding. And this came through with our grant approval awarded in February of 2020. I put this map together from their website so that you could see that we are the only grantee from the upper Midwest. So they are very much focused towards that East Coast. And part of their call really was looking for efforts that could be conducted in rural areas, and they had a specific interest in pregnant and postpartum women with opioid use disorder. So North Dakota doesn't get much more rural, and we had found ourselves with this nice little area of North Dakota that fit very well with the grant. So we're very thankful that they included us in this first round of funding. So where we are and what we do. So many of you, obviously being part of UND, are probably laughing at the North Dakota map, but it was really important for us when we present to FORE and all of our colleagues that are grantees, that they get a true understanding of where we are in North Dakota and how rural we are. So our grant covers this 8-county region in North Dakota. So we're kind of in this central north part of North Dakota. And we tried to give you a representation of kind of what we've done and who is included in our services. And so we stretch from Bottineau to Cavalier and over from McHenry to Ramsey County, including 2 of our tribal nations, as we talked about. Our little heart represents the DQTQ doulas, who we are going to talk about just a little bit. And then, as we noted, we are working with WIC. So all of the WIC offices that fall in our 8-county region have been included as part of our training. And in fact, we have even extended our training throughout the state of North Dakota, but starting and really focusing on our WIC offices that are in our region. So this kind of gives you an idea of where we are at. And these are truly some of our most rural counties in North Dakota. We have 3 aims, and that is access, education, and support. As far as access goes, we're really working to try to increase the number of healthcare providers who are able to be waivered and prescribed medications to treat opioid use disorder for women during that perinatal period. Our education is quite extensive. We are looking at increasing not only community awareness and education, but we've increased WIC agencies training and WIC staff training. We are also offering free monthly educational webinars that are open to anybody. So those of you who have an interest in maternal health, we would always love to have you come. And if you have students who are interested, they are absolutely always welcome. In addition, moms who choose to participate in Don't Quit the Quit can attend these monthly webinars and then become eligible to receive cases of diapers during the course of our grant. We are not only trying to increase awareness about opioid use disorder, treatment options, and just pregnancy and postpartum concerns in general, but we are actively working to decrease the stigma that is surrounding women with opioid use disorder. As part of growing our support, we are also developing a cohort of postpartum doulas. This is also something that's relatively new to North Dakota. We have had labor doulas in our state, and some of them have done some good work with the postpartum area, but we are specifically training people to become experts about postpartum and remain in their communities so that they could offer this extra level of support to mothers and families who have been impacted by opioid use disorder and substance use disorder. And we will talk to you about them in just a little bit. So always, I think, is helpful to understand why our work is important and what we're doing. And a couple of the slides that you're going to see here have come directly from the most recent data that's available from the National Survey on Drug Use and Health. This came out in September of 2020. And if we look specifically at the data surrounding women, you can see that 2 in 5 women with a substance use disorder are struggling with illicit drug use. 3 in 4 struggle with alcohol use, and 1 in 8 are struggling with both illicit drug use and alcohol use. If we look at where our major concerns lie with women who are using illicit drugs, we've really seen an increase in opioid use. Marijuana use has actually skyrocketed over the last couple of years, and we have never let go of methamphetamines. And we are seeing this being targeted for use in the female population as well. When we look at the extra layer to this, we know that women are at the highest risk for developing substance use disorders during their reproductive years. And for most purposes, that's about an age range from 15 to 44. We know that polysubstance use is quite common. So even though our grant is really focused on opioid use disorder, we understand that many women will come into this program with polysubstance use. We have a very high unintended pregnancy rate among women with substance use disorders. Nationwide, that rate is about 51%. With those persons who have substance use disorder, that rate goes up to about 80%. Substance use in pregnancy is connected to many complications and negative health outcomes for that mom-baby dyad. And this is incredibly important and something that we talk about all the time, that we have a dyad in that perinatal period. We're talking about the pregnant person, and we're talking about the infant, or the fetus and the infant, who are included with outcomes. Where the controversy and the stigma often come through when we're talking about substance use disorders in women is the fact that any substance has that potential to cross over to a fetus during pregnancy. And that's what often sends off those alarm bells and really starts that discussion going. When we look at opioid use disorder itself, I'm sure, I've got a very well-educated audience here, but just a reminder that opioids are a class of drugs that are used to reduce the intensity of pain. So they work in the nervous system of the body or in specific brain receptors. The definition of an opioid use disorder is a pattern of opioid use that's characterized by tolerance, craving, inability to control use, and continued use despite adverse consequences. And that is the part of the definition that applies across the board to substance use disorders, that it is this continued use despite those adverse consequences. We're really trying to get the message out that this is a chronic medical condition. It is treatable, and we have medications, behavioral therapy, and recovery support options for those who have opioid use disorder. The current terminology that's preferred is to use opioid use disorder. It's really interesting when you look at opioids and their use in the United States. And we really have experienced 3 different waves of opioid overdose deaths in the United States. So between 1999 and 2018, over 450,000 people died from overdoses involving any opioid. And that means that included prescription and illicit opioid use. Today, the data still tells us that 128 people die every single day from opioid use. So of those waves, the first wave that we recognize really started in the 1990s, and that involved prescription opioids. So we saw an increased use of prescription opioids at that time. In about 2010, the start of that second wave, we saw a rapid increase in heroin overdoses. And by the time we got to 2013, now keep in mind, we're really talking about a very short window here where this has shifted, but the third wave of overdoses became associated with synthetic opioid use, and particularly those involving illicitly manufactured fentanyl. So just the statistics are just staggering, and women are not immune. They are part of this population, and they actually do have their own period of time that we'll talk about where they experience higher rates of overdose. If we look specifically at women with opioid use, and again, this data is coming from the National Survey on Drug Use and Health, so 2019 data here, we know that 4.6 million women are with opioid use are in the United States. This kind of breaks it down to you to show that we've got prescription pain reliever misusers. We have those women who are using heroin, and then we've got a combination that they're using both of the different kinds of products. If we specifically look at pregnancy, this slide really breaks down that illicit drug use. So I love this slide because it continues to include tobacco products and alcohol. And remember, we talked about polysubstance use and misuse. And so we know that many women continue to smoke during pregnancy. And we know that upwards of 9 to 10% of women continue to use alcohol during pregnancy. And about 2.6% of them will binge drink during their pregnancies as well. When we break down that illicit drug use, you can see from the slide how much we had growth in marijuana use. And then we still have this pocket of those women who will use opioids and misuse opioids during their pregnancies. Pregnancy and opioid use disorder is associated with many negative outcomes, and that includes both looking at mortality and morbidity risks for the person who is pregnant, as well as the obstetric complications that will surround and encompass both her and the fetus. So we know that there's a 4 times higher rate of maternal mortality with women who have opioid use disorder, and women who live in rural communities are particularly impacted by this. And this is often secondary to socioeconomic disparities and our limited access to healthcare. We just don't have substance use treatment providers that are readily available, and sometimes we don't even have obstetric providers. And when we're looking for those that have experience in both, very rare in rural areas. We know that we have higher rates of co-occurring behavioral health disorders in women with opioid use disorder, and that is especially noted through the rates of depression. Women with opioid use disorder are particularly impacted by higher rates of postpartum depression, upwards of 40% within that first year postpartum. When we look at the different kinds of obstetric complications that women with opioid use disorder can experience, and I did put in parentheses here that, again, sometimes this is simply because of a lack of prenatal care. We see things like an increased rate of third trimester bleeding, placental abruption, where that placenta detaches from that uterine wall prior to delivery. We have higher rates of preterm labor and birth, and early passage of meconium, which tells us that these fetuses are feeling some stress secondary to that opioid use. We have seen a peak in opioid overdose occur in women during that postpartum period, particularly between 7 to 12 months postpartum. And again, this can be directly connected back to this lack of specialty services. We have not most, but 40% of women actually do not return to their obstetric provider for a postpartum visit. So we have women who have delivered and they're sent home with literally no connection to care. So if they do engage in care in that first year postpartum, it's often for an emergency, access through an emergency setting, or for a problem. It's not for routine healthcare. It's not for education. And as a result, we're missing this ability to educate them on many different kinds of warning signs, as well as making sure that they have been locked into continuity of care to treat their opioid use disorder. I also put in here that a lot of women, unfortunately, will experience overdose secondary to use that comes from the shame and the guilt that they are experiencing, that stigma factor, especially if their infant has been diagnosed with neonatal opioid withdrawal syndrome, that they're really feeling a lot of shame because of those symptoms that the infant is experiences. And then secondary to postpartum hormonal changes, we sometimes have some difficulty with dose adjustments. And so, women are often needing to be on a little bit higher dose of medication to treat opioid use disorder during pregnancy. And then when they become postpartum, we need to shift that because of how we're actually metabolizing those two medications, which would include both methadone and buprenorphine. As far as the fetal newborn impact, we know that opioid use on the maternal side of things reduces blood flow and oxygen to that fetus. So as a result, we do see overall growth defects, lower birth weight of these babies once they're born, and there is a connection to hearing loss. So infants tend to have to be screened more frequently for hearing loss or hearing deficits. We do know that this impacts brain growth, and we've seen a link to cognitive impairment and academic underachievement, which includes verbal, arithmetic, and reading abilities. Fetal distress is there, as we mentioned, and this is very tricky. So to date, we don't really have a lot of data that tells us that there are clear, visible physical anomalies. And sometimes this is one of the hardest things to discuss with pregnant persons, because you're trying to talk about these potential complications that can arise in the fetus and in the newborn, but they don't actually see these kinds of things. So for example, when we educate on alcohol misuse during pregnancy, we have something called fetal alcohol syndrome, where we see different facial anomalies. Eyes look different. The philtrum above the lip looks different. They're smaller, so we can see these kinds of things. When we don't have that physical connection, it's sometimes harder to sell the complications, talk about the complications that can be there. So it really takes a good deal of time to educate. And then, of course, we have complications that are primarily connected to those withdrawal syndrome or symptoms that the infant will have noted after birth. There are we talk about neonatal withdrawal syndromes in two different ways. So neonatal abstinence syndrome is the broader term. It's non-specific, and it's just a term that applies to any type of withdrawal presentation in the newborn. So this is not opioid specific. We know that this is an expected and treatable condition if we have had maternal substance use and misuse that will affect about 45 to 94% of infants. When we talk specifically about the symptoms associated with opioids, we have, since 2016, have been trying to use the phrase neonatal opioid withdrawal syndrome. Even if a pregnant person has been started on medications to treat their opioid use disorder, we know that they can have the infant can experience withdrawal syndrome at birth. So this again is expected and it's treatable, and we'll see this in about 30 to 80% of infants born to women taking medications to treat their opioid use disorder. It is extremely important to understand, though, that the presentation of symptoms is much more milder and it's more readily managed. And oftentimes we need less pharmacological intervention to manage when we are working with a family that is on treatment for medication or medications to treat opioid use disorder, as opposed to illicit opiate use. This is something that also requires a large amount of education for families. Typically, treatment for opioid use disorder leads to less severe withdrawal symptoms, and we see that we need less morphine to treat the symptoms. These infants have a shorter hospital stay, and they have a shorter length of duration of time that they need to experience this treatment. So this also, the shorter that we have them in that NICU setting, the more we can focus on bonding, the more we can get them home to their families, and we can create this healthier environment. I did want to mention a little bit of information specific to the rural impact because we are focused in a rural area. So women living in rural areas tend to have lower rates of initiation into prenatal care. This is often secondary to poverty, unemployment, and lower education levels. We see higher rates of complications in the pregnancy, as well as higher rates of infant mortality. We know that we have that lack of resources that we already talked about, but simply also including here transportation. How do they get to sites where they can have prenatal care? Do they have childcare options if they need to travel, or if they have to be placed in the hospital for a high-risk pregnancy or go see an infant who's in a NICU? Do they have childcare options for their other family members who are at home? We also know that they're less likely to have adequate outpatient substance use treatment services and these perinatal services. Interesting facts that we were able to get from the School of Medicine and Health Sciences is that we've seen a real limit to obstetric services being able to be provided in North Dakota, and in particularly our tribal communities. So you can see from to 2018 that the number of North Dakota cities where a woman could deliberately give birth dropped from 19 to 11. And about 1 in 4 pregnant rural residents now must give birth outside of their home community. So, just in the minimum, this means that they're losing that support system that they have within this community. As I mentioned, part of our education is to really work on decreasing the stigma that is surrounding women with opioid use disorder. There are many different definitions of stigma that's out there. The simplest one would simply mean that it is a negative belief about a person or a population. But there is one definition that we use a lot in our training, and that is that stigma is an attribute that is discrediting, and it reduces the bearer from a whole and a usual person to a tainted, discounted one. And this spoke to me from a feminine perspective, from a woman perspective, that when we have women in that perinatal period with opioid use disorder, we are immediately discrediting her value as a mother, her ability to mother, her ability to continue to be a key integral part of that family. So women are particularly impacted by stigma surrounding opioid use disorder and substance use disorder, and they do experience very unique differences from their male counterparts when it comes to stigma. Women are typically viewed as mothers, caregivers, gatekeepers, and being central to that family unit. And this means that when they have disclosed that they have a substance use disorder, that it's often been looked at as something that's quite selfish, and they told that this is a moral failure. Many people in society believe that when a woman has a diagnosed substance use disorder, it causes intentional harm to her family, to the child, and it places an added burden on us in the society. This strongly drives her sense of self-stigma, that internalized belief that is attached to blame, shame, and guilt. And it really triggers this struggle of whether she should disclose her substance use disorder or keep it a secret. Women tend to experience more economic barriers to treatment. We have less income, pay gaps, higher likelihood of living in poverty prior to the onset of substance use
Case
disorder.
management, this is Lori.
And then we know that stigma is disproportionately noted
Hi.
among women with women of color. Hey, Lori, we can hear your conversation. We also have a higher percent of women with substance use disorders who have a significant history of trauma. And keep in mind that this trauma might be victimization, sexual trauma, intimate partner violence, physical trauma, and mental and emotional trauma. And then women are more prone to social isolation. Even if you particularly think about those women who choose to be stay-at-home mothers, we have a whole different sense of social isolation and higher rates of co-occurring disorders. Pregnant women with substance use disorders are increasingly stigmatized and prosecuted for substance use, which leads to financial, emotional, and legal consequences very unique to this population. When mothers are in their first year postpartum, we also find that now we've gotten through that pregnancy, but that stigma doesn't go away. They continue to perceive that stigma being delivered from healthcare providers, the public, their support systems, and very interestingly, even from the addiction community. So if they've engaged in peer support or participated in their addiction support community during their non-pregnant state, once they become pregnant and become mothers, the addiction community stigma tends to worsen. So they've been able to describe that they're noticing it even more so within that addiction community at that time. I always include preconception when we talk about stigma in women, because many of us who work in healthcare also have these preconceived biases and stigma related to who we really think should be able to become pregnant. And so if a woman presents for prenatal care, or she says she would like to consider becoming pregnant, and she has a history of a substance use disorder, or has an active substance use disorder, or is in treatment for a substance use disorder, we automatically shift gears and we think, what is this going to do to that baby? Now, remember, we talked about this. We have a dyad. So, just as if somebody would present and have uncontrolled diabetes, uncontrolled hypertension, we would still need to educate. We would still need to talk about chronic medical conditions that need treatment and that can be treated during her pregnancy. So really thinking about that preconception stigma that's there as well. And then we have to remember that as many as 70% of women who enter into addiction treatment have children and the primary responsibility to care for those children. So mother gear shifts in, and how are they going to be able to attend treatment sessions if they don't have anybody to help with childcare? Maybe they have a partner, but they're not comfortable leaving children with that partner. And their greatest success in treatment is going to come if they can attend that treatment. So this really impacts their ability to even access treatment. When we look at the overall consequences of stigma, perception, and biases, we see that pregnant persons and women during that perinatal period often have a poor self-image, poor self-esteem. They experience shame and embarrassment, fear, anxiety. They become very defensive. It leads to suboptimal prenatal care, just as we've talked about. And then many of them will just simply choose not to engage in treatment. And we do see, because of punitive actions that are out there, even this connection to incarceration and death from overdose if they have not been able to seek care. So how are we working to address the impact of opioid use disorder in rural North Dakota through Don't Quit the Quit? And we'll go back to those three kind of topics. And so access, education, and support. So we really, I said our grant was awarded in February of 2020. And by the time we got through IRB and got everything ready to roll, we were really looking at May before we were able to start thinking about training and working with healthcare providers, recruiting, and all of that kind of thing. So since we were able to start doing this in about May of last year, we have several clinic systems who have now come on board and have decided to participate with us. And we are incredibly thankful for their support. So we have a physician assistant through Heart of America Medical Center. We have a family nurse practitioner who is also waivered at Presentation Medical Center. We have 3 family practice physicians who do work in obstetrics as well that are waivered at the All True Devils Lake Clinic site. And they have 1 family nurse practitioner at Spirit Lake Nation who participates in a shared obstetric program with them. So that means that she will often start seeing pregnant persons in Spirit Lake at her local clinic, and then she will work to transition that care as they come closer to the time of delivery to the All True Devils Lake site. We are very proud to let you know that this provider is Kristen Gorno, who is one of our graduates and was part of our RAIN program as well. Towner County Medical Center participates with us, and we have 2 family nurse practitioners that started with us and 1 newly waivered FNP who is also a graduate from our program. And she just became waivered in December, and 1 physician's assistant who is also waivered there. And then Northland Community Health Centers has a couple satellite sites, and we have 1 family practice physician who's waivered and 2 family nurse practitioners who are waivered at that site. So we have a mix of experienced waivered providers and newly waivered providers. And what we learned real early on is that even though some of these providers had been waivered for a while, they just weren't comfortable expanding that practice to women during the perinatal period. And that's why we really feel that mentoring is so incredibly important to continue to provide them with support as they learn to do this. I did add that we are still recruiting, so we're always looking for providers in our region to join us. So Dr. Henke was integral to the training that we were able to offer to our providers. We offered 2 close to about a 90-minute trainings for our providers over last summer. And we really talked to them about opioid use disorder during that perinatal period, talked in detail about the medications and their waiver training. And then Dr. Henke checks in at least quarterly with all of our providers to see about mentoring needs. And our providers have access to her at all times, through email, phone calls, and when an option to even travel to her Heartview Foundation to see her work and learn from her. We provided all of our providers with resources built into flash drives where we can continue to update clinical practice guidelines, cool articles that we find, references, just to give to them so that they can go ahead and continue to stay updated on all of their all of the new information. And all of our providers and staff at these clinic sites went through orientation training with us. This is a quick look at what our intro pack looks like. So all of our moms are provided with a bag. We chose this bag, 1, because it's environmental friendly, but it also is the perfect size to hold things for those quick mom trips. A few diapers, a few little toys, formula if needed, or breastfeeding supplies, and have it be a lightweight bag that they can just take with us. The little card that you see down in the corner is actually what we refer to as a passport. And this is a place where mom can keep track of all of her appointments for medications to treat opioid use disorder, as well as WIC appointments, and then keep track of the times that she's able to attend our webinars so that she's able to become eligible to receive those cases of diapers during the program. From the education, we've mentioned now a couple of times that we offer these free educational webinars that you are, of course, all invited to. So we meet on the first Thursday of the month at 7 p.m. via Zoom. And we cover all topics related to pregnancy, postpartum, and I've given you a little list of some of the topics that we've already covered. We've had really good response. We always want to grow our attendance, however. So our next topic coming up in March is going to be focused on reproductive and sexual health needs for women with substance use disorders. As far as our WIC training, we also had about an hour and a half to 2 hour training with all of our regional WIC agencies this past summer. They are so important to continuity of care and referral for care for women who have substance use disorders and opioid use disorders. WIC by far has the best engagement with women in that postpartum period. So they get to know them during the pregnancy and they stay with them for several years postpartum. So we also provided them with foundational information on SBIRT, which is screening, brief intervention, referral to treatment, because they are required to screen for substance use during their WIC appointments. And then we educated them on stigma. In January, we held a nutritional webinar that was provided from Dr. Amir Alakam, a former faculty member with us at UND. We did have some audio trouble that day. So he has actually re-recorded that presentation and we are now putting it on our website. So it is available. It's about a 40-minute presentation and he really looked at nutrition needs during opioid use disorder. It was great. So we hope that you all travel to our website to take a listen to that. And then WIC has asked us to actually put our training on North Dakota Train so that we can disseminate WIC training statewide. As far as our postpartum doula support, I'm going to turn this over to Abby at this point, and talk a little bit about the training that we are doing to grow a cohort of postpartum doulas.
Hello, so I'm Abby Moore and I am the program coordinator for Don't Quit the Quit. But Maridee is truly the brains behind this operation. So to bring postpartum support to rural North Dakota, the idea was to bring in postpartum doulas because they offer that postpartum support, but it's more accessible for people. So one of our first contacts was Tracy McPhillips, who is on today, and she is just wonderful. She has been with us from the beginning. She is our I like to say our postpartum doula trainer. She has provided 2 sessions now where we've had doulas go through and complete I'm not sure on the hours, but the 3-day training, the 3-day initial training for you to become a postpartum doula. And that's the part that Don't Quit the Quit is providing for people. We have doulas now, and then we have, by the end of April, we have 9 doulas, and we are so excited about this. So our next workshop is in March, and then by April, we'll have 9 doulas in our cohort, and it is just wonderful. So the next slide. So Tracy is a trainer through DONA. So all of our postpartum doulas will be DONA eligible for certification after they complete the whole course. They're educated on normal postpartum adjustment, and we receive training that is just experts in normal is how it was described. Is we kind of are educated on normal fussiness, normal behaviors, normal adjustment, all that kind of stuff. So we are able to offer emotional support, evidence-based information and support, practical support like cooking and laundry, and maybe even just watching the baby while you take a nap, all that kind of stuff. And partner and sibling support as well. If you're having trouble adjusting to having a new baby, we can kind of help offer support into integrating a new baby into the family. So our Don't Quit the Quit doulas will be a little extra special though, because not only are they getting the foundational knowledge of postpartum doula work, we're also bringing in cultural training for our doulas to help Native American families. And that's why we have Rain and Kara on board to help us integrate into those communities and bring on local support and local people to offer this wonderful service. Next slide. And in a room full of medical professionals, we wanted to be sure that we let everybody know that postpartum doulas are not a replacement for medical care. We are really just a resource to think about your provider and what was talked about. And we're really just a resource to connect. And as a social worker, it feels really natural to be that person to connect people to resources and not necessarily be that resource. So postpartum doulas do not educate on their own beliefs or personal experience. They do not judge clients, family members, or friends, which is so important, especially talking about stigma. We're not there to judge, we're there to provide support, and that's it. We will not diagnose conditions. We are trained in recognizing signs and symptoms of some postnatal, what is it called, Maridee? Postnatal depression and all the things that can come along. What were you going to say?
Yeah, perinatal depression or postpartum depression.
Yes.
Yes, exactly. So as Abby's saying, they might recognize those symptoms and then be the ones to refer, say, hey, you might want to go talk to somebody about those things.
So to talk to your provider, to talk to somebody, to talk to your spouse or other moms or just somebody, so that we're there to just point out maybe what we're seeing. We're not there to overstep boundaries, to tell new parents how to do things with their baby. We're really just there to guide and offer support where it's needed. And we're not there to perform clinical or medical tasks. We're not even supposed to tell women to take ibuprofen or Tylenol. Really, we're there to just remind women to listen to their providers and listen to things that they've been told. So next slide. So the part that we are offering through Don't Quit the Quit is the workshop. So we pay for that for our Don't Quit the Quit doulas, but then for them to actually get certified, they're going to need to do extra breastfeeding education. There's reading requirements, a self-assessment, and there's all sorts of stuff that has to go in on top of what we offer. But really getting the ball moving for people in these communities. Next slide.
Yep. And what I will add to that is that all of our Don't Quit the Quit doulas are eligible for a stipend at the end of our grant program to help them achieve their goal of becoming certified and to start their practice work in their communities. So let me get, here you go.
And this was just something funny. We are both, Maridee and I, are new at social media. Even though I am of the millennial generation, social media is somewhat foreign to me. I know how to operate it. I know how it works, but it's new. So we came up with this. To be is to do is something that Socrates said. To do is to be. Jean-Paul satire, maybe. Doobie doobie doo is Frank Sinatra. And be a doula is our very own Maridee Shogren.
So we do try to have some fun and we want people to enjoy the work that we're doing. And so we actually posted this to our Facebook site, but we believe in the mantra for sure. So a couple of things to finish up, or just to be able to share with you the things that you can do to help support Don't Quit the Quit. We really try to remind everybody that our language matters. We want to look at addiction as a chronic disease and not a moral shortcoming. And we want to get in the habit of using non-biased language in healthcare encounters. So we gave you a little list on the side of things that we would suggest. So talking about being in recovery as opposed to being clean, not having a dirty test, but maybe a positive drug test. Trying to get not use the word relapse, but look at recurrence of use. So just really trying to make this more person-first language when we're talking about substance use disorders. We strongly believe in education, and that means that we present and discuss the facts, but we also, more importantly, correct misinformation. Truly, one of the biggest things that we run into as far as misinformation is hearing people say that babies are born addicted when they've been born to a mother who has an opioid use disorder or a substance use disorder. What we're really seeing is that babies are not born addicted, but they are born experiencing the symptoms of withdrawal. So again, just really important to shift that language. We want and encourage extra training for all healthcare professionals, and then we're really growing that community awareness about opioid use disorder. We ask that you help us promote health and decrease stigma. The World Health Organization has defined health not merely as the absence of disease, but the presence of optimal social, psychologic, and physical well-being. So we want people to keep that in mind, and we want people to understand and advocate for prevention and treatment. We do ask that you support providers and that you really support North Dakota providers who care for women with opioid use disorder. Families, caring for families who have been impacted by substance use disorders is difficult work. It's often connected to ethical distress, moral distress, and many experience compassion fatigue. So it's really helpful for all of us to become more aware of our own biases. We all have them. We all need to recognize them. We need to grow our knowledge. We need to learn about intimate partner violence and that family dynamic that surrounds families impacted by substance use disorder. And becoming aware of local and state treatment options helps us refer families and moms to treatment sites. We also need to engage in self-care. And quite frankly, we need to do a better job about being kind to each other. So here's where you can find us. Abby's done a great job getting our website up and running. So we're at und.edu/DQTQ. Please visit our site. We have a Facebook page and we try to post at least a couple of times a month to with additional facts and information, or we just tell you about upcoming events. And we now have a brand new Instagram site where you can find us as well. As noted, it's multiple times, we want you to attend. Please come to our free webinars and please encourage your students to attend. It's a great way if they have an interest in maternal health to get some free knowledge. And if you happen to know mothers or families who've been impacted by opioid use disorder, please let them know about our work. All of our providers are also listed on our website. So just by going to our website, they can see if there's somebody locally where they can access treatment options. This means they're not going to have to travel 2 hours, 3 hours to get care, but they can stay in their home communities to do this. And then we ask that you always empower women to be partners in their healthcare. So with that, we'll go ahead and stop and we'll turn it over. I think we have time if there's any questions.
I also did a shameless plug in the chat box. If you wanted to follow us on Facebook, we would not hate it.
But at last count, we had like over 120 followers. So we're kind of feeling like we're a big deal these days.
You are a big deal. That was a great presentation. Does anybody have any questions? You can either write it in the chat box or just turn on your mic and ask your question.
This is Gail. Maridee and everyone, the entire team did a fantastic job. One of the things that I always look for, of course, is what you'll do in the future. And you did mention the fertility and the subsequent pregnancies. Do you think in the future you would do more education on birth control, family planning, spacing your pregnancies? That's always a sensitive topic also, because again, you don't want to, circle it back to their feelings of lacking confidence regarding mothering. And yet, if they can focus on themselves and their family at present until, things are in a better physical condition for them, it increases the likelihood of a healthy pregnancy. What are you seeing about subsequent pregnancies?
Okay, so first of all, I would say that if anybody knows me, they know I've worked in family planning and I just believe in contraception for all, if that's what they desire. So it's really important that we are able to provide information, not just on contraception, but all reproductive health needs. We have found that many women with substance use disorders have found themselves being coerced or forced into certain types of contraception, and that's not okay. We actually are quite privileged as healthcare providers with the information that we hold regarding contraception. So we need to make certain that we're presenting them with all of their options and supporting their choices, as well as looking at family planning in general. So women with substance use disorders do have that higher rate of unintended pregnancy. So we do want to include that information for them. And that is something that we'll be talking about during our March webinar. Part of that presentation will also look at the unique challenges that we have in rural counties regarding reproductive health services. So a lot of times women with substance use disorders will find themselves also not having access to reproductive health care. That includes mammograms, Pap testing, screening for sexually transmitted infections. They all are wrapped into that bubble of reproductive health needs. But I think everybody benefits from the education surrounding what kinds of contraception options are out there, what's available, and what might work well in their lives. It's also really interesting because women with significant and chronic substance use disorders often stop having their menses, and they are under this belief that they cannot become pregnant. So once they engage into treatment and cycles start returning, they don't realize often that they can conceive. So it's really important to get that education to them in a timely fashion. And sometimes when they're in treatment, that is the best time to start that education.
There's a question in the chat box that asks if we have any publication on this work or maybe future considerations for publication.
Sure. So yes, Gail. We will look at doing some future publications. We did have, we'll look at, how, I don't know what format that will look like at this point, but I've actually been very, very lucky in the form of presenting to the public. I've gotten to be part of a reproductive health services panel that was presented out of the Ohio State University that went nationwide. I also am very fortunate to work on both of our TTCs, our Technology Transfer Center networks, where I get to talk about some of the same information. So we did have a publication that came out last April in the Canadian Journal of Nursing Research that really focused on stigmas. And particularly, I got to talk about the unique role of midwives to be able to decrease that stigma that's there. All of our webinars are recorded and they're put out for that education, which is a type of publication for that to be out there. And then for those of you who may be really interested in just that overall concept of stigma, through the TTC side of things on the addiction technology, we have a healthy knowledge course, a 4-part series of education that's available free for that. So from a journal sense, yes, we will look at making some publications, but please know that we have a lot of readily available public information already out there for you too.
Any other questions? We got about 10 minutes. There's been lots talked about, so or you can, I'm sure, contact Maridee or Abby privately if you have additional questions.
I'll throw out a question, even though I'm on the team. Can you talk about reimbursement for doula support services and during the pandemic?
Well, sure. So we also need support in this area. So right now, there are 4 states who will reimburse for doula services, but they're typically labor support services. Minnesota actually is a neighboring state who does that. And right now that reimbursement for Medicaid clients is about $400 for that particular service. To date, we do not have states that have been embracing postpartum doula services. So we need action in this point in this area. So this is one thing that we hope to be able to tackle to provide more information and possibly connect with our state representatives to see if we could look at getting something like this started. We are working with a Native American group out of Bemidji. And they have done some work for getting doula support in Minnesota. So it's been great to hear from them, about those possibilities. The other thing that's going on legislatively is that they're finally looking at changing the definition of postpartum to looking at that being beyond 8 weeks postpartum to the full first year postpartum. And if we can do that, that means that we can increase that accessibility to covered services for up to a year for women. Postpartum doulas would fit in this realm, contraception would fit in this realm, and we could actually look at more routine preventive care to be offered in that full year. So this is a really good place to focus some of this work. And I don't know, Tracy, if you want to wave, Tracy is our esteemed doula. And if you have anything that you would add as far as the doula scope of things, you'd be welcome to.
I'm good. Abby just knocked it out of the park. Thank you with that, Abby. I think that was fantastic. I love that you talked about normalizing, and I feel like with the community that there's so much stigma, and bringing in normalcy into parenthood is remarkable. So thanks for your great words, Abby. Nice job.
Thank you.
And keep in mind that with our doulas, as Abby said, our doulas will not engage with families during the course of the grant. That was a stipulation of FORE. So instead, we're turning this to opportunity. How often do you get an extra year to just learn more? And, even if in our rural families where we tend to have maybe closer knit families structures, sometimes that support goes away once an opioid use disorder or a substance use disorder comes into play, and families aren't necessarily the most supportive in that realm. So by having more education for the DQTQ doulas, they're really learning about this. They're learning to grow that non-judgmental support. And in addition to that education surrounding substance use disorders, we're also adding in more breastfeeding support, cultural training. I mean, these doulas are going to be so well equipped at the end of the grant that they will truly be those experts in these rural communities. And that is what's important, is providing that expertise locally.
And there's a question in the chat box. Can you elaborate on the interdisciplinary benefits of this work? I love, you love interdisciplinary.
I don't know, somebody else, Abby, you're cutting
heard us
in
talk
and out.
about race or.
Abby, you cut out through that entire question. I'll go ahead and say, this is from Isaac. Can you kindly elaborate on the interdisciplinary benefits of this work? I heard of RAIN, so nursing, public health, and social work.
Sure. So we are just very fortunate to have that varied expertise right within the team itself. So Abby comes from a social work background. Our colleagues from RAIN just come with that nursing background, social work background, and community expertise. We've got our evaluator who's looking at making sure that we're publishing and looking at IRB kinds of things. But all of this has come together to allow us to be able to talk to a broader audience. We've got a physician mentor. We've got somebody who's a director of a substance use treatment facility who weighs into that. So we learn from each other every single day. I think probably one of the most unique partners is WIC. You know, we forget about the importance of nutrition in recovery and the accessibility that women have through WIC to gain extra support. And so by broadening this and really not limiting ourselves to say, well, this has to just be a nursing focus, we don't function that way in real life. We include services from so many different specialties in real life that is mimicked in our grant work.
All right, we're at 12:55. A great time to stop now if there are no other questions. Last call for questions.
Okay, this is Gail. I have a quick question to a rather odd situation, but how do you think COVID is impacting this situation? Of course, we know that the substance use disorders have increased. So what are you seeing with the facilities that you're working with, the women that you're working with? What are your impressions on how it's impacting them?
So the first thing I'm going to say is a little plug to go to our website, because we did one of our monthly webinars on it basically is when pregnancy, COVID, and substance use disorders collide. And we really talked about this tri-directional relationship where COVID has changed not only prenatal care, but substance use treatment care. So I think in our region, you know, often what we see is that it's been difficult to access that care in the first place. And then with COVID, many rural facilities haven't been able to fully implement telehealth yet, for example. So how do we still get that access? From the grant perspective, secondary to COVID, we still have not been able to go meet our collaborators and our partners face to face. We haven't been able to make that connection that is so important in rural and in tribal communities. You know, we need to sit down, we need to have that cup of coffee, we need to talk and brainstorm, and that COVID has really impacted that. So I think we're seeing more isolation. I think we're seeing a delayed entry into prenatal care, a delayed entry into substance use care. When that delay was already present simply because of the nature of substance use disorder, it's been further impacted by COVID. So once we kind of start seeing our numbers come down, and don't forget, North Dakota was known nationwide for having some of the worst rates out there. So now that we're getting into a less responsivity rate with COVID, positivity rate, now I think that some of that is going to open up, and that people are going to become more aware and be more willing to engage in that treatment early.
All right, wonderful. I think this is a great topic, great presentation, and I think we're ready to sign off.
And I forgot, five of you lucky attendees will get some DQTQ swag. We're giving away one of our bags and 4 pens. So 5 of you lucky people will be hearing from us. Random drawing.
Everybody's names, so.
Perfect. So thank you so much for having us and spending time with us today.
Thanks so much. It was great.
Wonderful. Thank you, everybody.